I am Dr. Sharjeen and you are watching my YouTube channel. Today we have taken 4th year ophthalmology stage in glaucoma, cornea and retina. We gave 25 MCQs to the class and they attempted in 30 minutes. Many students at the end of the stage requested that I should solve the stage with them so that they can better prepare for the final exams. So here I am. I'll discuss each and every MCQ one by one. Whenever we take MCQ exams, it is a blend of scenario based MCQs and one-liner straight questions, because we take into account the time given to the students. So let's start with the first question. The first question is, which of the following is not included in the treatment of keratoconus? Now keratoconus is one of the most important corneal ectasias, corneal disease in cornea chapter, and 4th year students, undergraduates, they are required to know the basic pathology, the definition, its signs, symptoms and treatment options. So here we have got 5 options. For progressive keratoconus, we perform corneal cross-linking. So that's a treatment option for keratoconus. Then keratoplasty, when there is a corneal opacity after acute eye drops. Then keratoplasty is also performed. For early keratoconus, we have options of glasses and then contact lenses, rigid gas permeable lenses. But there is no medical treatment of keratoconus. So that's the answer, E. Now let's come to the second question. Which one of the following diabetic retinopathy stage does not require treatment? Now in a retina chapter, the most important topic for students is diabetic retinopathy, and you should know when to treat and when not to treat. So the first option is proliferative diabetic retinopathy. Now proliferative is an advanced stage of diabetic retinopathy and we treat proliferative disease. Then if a person comes with a tractional retinal detachment, whenever there is a word retinal detachment, it means you have to treat it urgently. Then we have got macular edema. Macular edema, fovea is the most sensitive part of the vision. So when there is edema, there is a stretch on the cones, you have to treat it. Then there is option D, background diabetic retinopathy. In a background diabetic retinopathy, we have got aneurysms, dot blot hemorrhages, hard exudates. So this is the stage where we can follow and observe, but we don't need treatment. And then vitreous hemorrhage. Now vitreous hemorrhage also comes in proliferative diabetic retinopathy, so you have to treat vitreous hemorrhage. So the answer of question 2 is background diabetic retinopathy, D. Now let's come to the third question. Now it's a scenario. 45 years old woman presented in an eye emergency late night. Now it's a woman presented in emergency, so it's an ocular emergency with complaint of sudden painful decrease of vision in the right eye for last 3 hours. So it's a sudden painful condition in a lady. According to her, she was all right up till evening and then suddenly developed painful decrease of vision while reading book. So in the evening the pupil dilated and she was reading book and she developed the pain. In a mid-dilated state, it means that the angle was narrow and acute angle closure attack occurred. So it was associated with episode of vomiting and nausea. Her eye is red, watery, vision is counting fingers, and there is corneal edema, mid-dilated non-reactive pupil. So it's a very straightforward scenario of acute congestive glaucoma. So answer A, the option A is right. In acute anterior uveitis, you will not have that much pain. In glaucoma flecans, also this scenario doesn't fit acute migraine, Posner-Schwarzman syndrome. So all these are the differentials, but it's a typical scenario of acute congestive glaucoma. Now comes to question number 4. A 59 years old hypertensive patient, old age, hypertensive, presented with sudden painless loss of vision in the right eye. On examination, bilateral anterior segments normal. Fundus showed flame-shaped hemorrhages all around. Left eye was normal. What is the most probable diagnosis? Now one eye is totally normal and one have got flame-shaped hemorrhages. So it's not diabetic retinopathy. So whenever you get flame-shaped hemorrhages all around the fundus in a hypertensive patient, it is central retinal vein occlusion. The other options, in central retinal artery occlusion, you will have a pale fundus with cherry red spot. In cataract, you will have normal fundus. In optic neuropathy, you will have a normal fundus but pale disc. In vitreous hemorrhage, you will have no view. Now, which of the following diseases respect horizontal midline on visual fields? Now, I have discussed it in detail in class on the whiteboard. So, glaucoma respects horizontal midline, and neurological defects like visual cortex lesion, optic radiations, optic tract lesions, they all respect vertical midline. So, the answer of question 5 is glaucoma. And optic neuritis will give you central scotoma. Now the 6th question is 80 years old non-diabetic non-hypertensive patient presented with sudden loss of central vision in his left eye. On examination, his right fundus showed yellow colored lesions at macula and left fundus showed hemorrhage at macula with greenish subretinal membrane. What is your diagnosis? So 80 years old, non-diabetic, non-hypertensive, a very old patient, sudden loss of central vision, and you get yellow color lesions in the right eye. So it's a dry AMD in the right eye, and left eye have got greenish subretinal membrane. So it's choroidal neovascular membrane, CNV. So it's a case of AMD, age-related macular degeneration. Now question number 7. Intravitreal anti-VEGF injection is used in all of the following diseases except. So these are the options: A, optic neuritis; B, central retinal vein occlusion. Yes, in central retinal vein occlusion there is macular edema, so we give anti-VEGF injection. In age-related macular degeneration or wet AMD, there is choroidal neovascular membrane formation, so we give anti-VEGF. In diabetic retinopathy, we give anti-VEGF injection. In macular edema, we give. But in optic neuritis, we don't give anti-VEGF. So option A is correct. Now question number 8. 10 years old patient complains of decreased night vision. So when there is a decreased night vision and you have got a triad of RP, bilateral disc pallor, hyperpigmented spots, vascular attenuation. So it's a case of retinitis pigmentosa. The other things, the other differentials, they also can present with night blindness. But in albinism, you will have white skin, white hair, nystagmus, transillumination defects. In age-related macular degeneration, it will be an old patient. In high myopia, he will have a refractive error along with night blindness. Now question number 9. 75 years old cardiac patient presented with sudden painless loss of vision in his right eye. On examination, his vision was perception of light in the right eye. Now extremely severely decreased vision in an old cardiac patient, painless loss of vision, relative afferent pupillary defect is positive, pale looking retina with cherry red spot. I have already told you that cherry red spot, pale fundus, old age, cardiac patient, so it's central retinal artery occlusion. Now comes to the 10th. 18 years old myopic patient presented with sudden painless loss of vision in his myopic patient. So he has got a thin friable retina. In a myopic patient, so we tell them that you don't rub because your retina is thin and it can easily get detached. So with sudden painless loss of vision in the left eye, and fundus shows detached retina with U-shaped tear. So what is most probable diagnosis? It's a very clear-cut case of rhigmatogenous. Rhigmatogenous means, rhigma means break or tear. So it's a rhigmatogenous retinal detachment. Then comes the 17 years old patient presented with sudden painless loss of vision in the right eye, and right fundus shows detached retina with large tear more than 3 clock hours. Now a tear more than 3 clock hours means giant retinal tear. Now giant retinal tear cannot be closed by external tamponade like buccal. You cannot observe it. You cannot give anti-VEGF injection or gas tamponade for such a large tear. So you have to perform internal approach of pars plana vitrectomy. So question number 11 have got A option, pars plana vitrectomy. Then question number 12, which of the following is not a risk factor in the etiology of retinal detachment? Now in high myopes, we have already discussed 18-year-old myopic patient in question number 10 who has got retinal detachment. So high myopia is a risk factor for retinal detachment. Then trauma, definitely trauma can detach. Trauma can cause rhigmatogenous retinal detachment. Then retinal degenerations like lattice, snail track, they can also predispose a patient to retinal detachments. Diabetes, in diabetics can also get a retinal detachment like tractional retinal detachment, but hypermetropia is not a risk factor for retinal detachment. So 12 have got answer E. Now 13, a 50 years old patient is diagnosed with mature cataract and there is no view of the retina. Now in a mature cataract, there is no view of the retina and the patient wants a good vision. You are not aware that whether retina is attached, detached, whether there is a vitreous hemorrhage or not. So there is a no view. So in an opaque media, we perform B-scan ultrasonography. So option C is correct. MRI we perform in optic neuritis to see the brain in tumors. CT scan can also be performed to know the extraocular muscles in thyroid eye disease, to see the bony in a trauma patient, to see the bony fractures. B scan for opaque media in the eye, OCT for glaucoma and macular disorders, and tonometry also glaucoma. Now 14th question is 21 years old female presented with sudden decrease of vision in the left eye associated with moderate ocular pain. Now pain is not that much. On history, there was a fingernail trauma and rubbing of that eye as well. So fingernail trauma to the cornea, on slit lamp examination there is a round central white patch on the cornea with smooth edges. Now edges are smooth, central white patch, it means it's an ulcer, corneal ulcer with smooth edges and surrounding infiltration, and there is a mucopurulent discharge. So it's a bacterial keratitis. In a Acanthamoeba keratitis, there will be severe pain, contact lens history, or swimming in the fresh water, and there will be the ulcer will be small and the patient will be pain will be out of proportion. In a herpes keratitis, you will get a typical dendritic pattern. In a candida or fungal keratitis, there will be vegetative trauma history, or pain will not be that much, and there will be hypopyon and endothelial plaques. And in a sterile keratitis will be at periphery, there will be rheumatoid arthritis or other joint diseases, and it will be painless. Now 56 years old patient presented with sudden loss of vision associated with floaters. Anterior segment normal, fundus showed vitreous hemorrhage. So floaters with vitreous hemorrhage, all of the following are risk factors for vitreous hemorrhage except. Now in a diabetics, in a proliferative stage, you can get vitreous hemorrhage. In a retinal vein occlusion, you can get neovascularization, which are fragile vessels that can lead to vitreous hemorrhage. Trauma is one of the common causes of vitreous hemorrhage. In Eales disease, you also get vasculitis, and you can get frequent vitreous hemorrhages in a young patient in Eales disease, but glaucoma is not associated with vitreous hemorrhage. Now in 16 question, 50 years old myopic lady presented with painless blurring of central vision in the right eye. There was a dark spot at the center of the fovea. Now you projected a line on fovea on slit lamp, and patient said it is broken in the center. Now it's a Wadsky-Allen test. Wadsky-Allen test is performed in a macular hole patient when there is a defect in the fovea. And causes of macular hole, one of the common causes of macular hole is myopia. So, and the other is trauma. So, and it can be idiopathic as well. So it's not a cystoid macular edema. In a cystoid macular edema, the line, the projected line will be not broken, but it will be deviated. It will not be straight. In a macular hole, it will be broken. In a diabetic macular edema, again it will be deviated, not straight. In a central serous chorioretinopathy and all these, the line will not be broken in the center. Now 17. Which of the following is the first line medication in open angle glaucoma? Now prostaglandin analogs, they are first line medication because they are given once daily and have got good effect to decrease intraocular pressure. Now question number 18. 20 years old female, now she has wore cosmetic contact lenses to attend wedding. So she slept with that cosmetic cheap lenses, and next morning she had got severe onset pain, redness, watering, and decrease of vision more in the right eye as compared to the left eye. Now the most likely diagnosis is, now it's with a severe pain. So severe pain and contact lens history, so it's a case of acanthamoeba keratitis. Now which of the following is not surgical procedure for glaucoma? Now that was a tricky question. Now let's again come to the 18th question, that fungal keratitis, we have already told you that it will have a fluffy margins, zigzag margins, hypopyon and less pain. In a viral we will have dendritic pattern. In autoimmune we will have no pain. In a peripheral ulcerative keratitis and severe pain in mural ulcer, but that will be on the periphery. So we have got two options left: bacterial keratitis, B, and C, acanthamoeba. And both, especially pseudomonas keratitis, is also associated with contact lens wear, but severe pain will occur in acanthamoeba, so we should click C in that. But it's a little bit confusing. Now, which of the following is not a surgical procedure? So all those procedures in which we have got ectomy, that are surgical. So first C, in which we have got ectomy. Option A, trabeculectomy, so it's a surgery. Iridectomy, E option, so that is also surgery. Now we have got B, C and D. We have got trabeculotomy, C goniotomy and D iridotomy. Now we know that in a childhood glaucoma, if we have got a clear cornea, we perform goniotomy, and if we have got a hazy cornea, we perform trabeculotomy. So these are also surgical procedures. But iridotomy is done with lasers. Laser, so its full name is laser peripheral iridotomy. So option D is not a surgical procedure, it's a laser procedure, whereas all others are surgical procedure for glaucoma. Now question number 20. 56 years old, uncontrolled diabetic, presented with blurring of vision. There are bilateral cataracts and bilateral proliferative diabetic retinopathy. How will you treat him? Now the options are pan-retinal photocoagulation, pars plana vitrectomy, cataract surgery, observation, all of the above. Now again come to the scenario. Now you can see that the patient have got proliferative diabetic retinopathy in both eyes. So when the diabetic retinopathy reaches a proliferative state, you cannot observe it. So observation is wrong, which was option D, and option E was all of the above. So all of the above is wrong, observation is wrong. So we have got three options, A, B, C: pan retinal photocoagulation, pars plana vitrectomy and cataract. Now mild cataracts. Now if you operate cataracts which are mild, it will also increase diabetic macular edema, so it will have adverse effect on proliferative diabetic retinopathy. So cataract surgery is also not an option. So we have got two options, pan retinal photocoagulation and pars plana vitrectomy. Now pars plana vitrectomy in a diabetic patient we perform when there is a hazy view, when there is a dense vitreous hemorrhage, fractional retinal detachment. So that is also not that stage. So the option of the correct option in question number 20 is pan retinal photocoagulation. So now comes to the question number 21. 60 years old man presented with complaint of sudden painful decrease of vision in the right eye for last 1 week. Again painful decrease of vision in an old patient. He had episode of vein occlusion 1 year back. So he had a vein occlusion 1 year back in the same eye, and vision was 660 after that. Now it is counting. So vision has worsened in a vein occlusion patient. So it means that the vein occlusion was ischemic, and slit lamp examination shows vessels on the iris with corneal edema and red watery eye. So there is pain, corneal edema, red watery eye and vessels on the iris. So vessels on the iris means rubeosis iridis, and corneal edema, red watery eye, counting figure vision. So they all goes in a direction of neovascular glaucoma. So it's a case of neovascular glaucoma. In a lens induced glaucoma there will be some lens pathology which will be given in the scenario. In a pigmentary glaucoma there will be also a clear cornea, there will be no vessels. In an angle closure glaucoma there will be no vessels on the iris. So the answer of 21 is neovascular glaucoma. Now question number 22. Corneal sensations are diminished in which of the following conditions? Now in conjunctivitis we have got good corneal sensation, in fungal keratitis we have got sensation, in marginal keratitis and bacterial we have got. So in a viral herpes simplex keratitis there is corneal anesthesia. Now 23. Gold standard instrument for measuring intraocular pressure is Goldman. Gold standard and Goldman. You can remember it, gold standard Goldman. Now question number 24. A 25 years old male patient presented to you with 6/6 vision, both eyes, and IOP right eye 16 and left 18. His anterior chamber is deep. On fundus, his cup disc ratio is in the right eye is 0.4 and left 0.7. So there is a cup disc ratio asymmetry. So that makes this patient glaucoma suspect. Now which two tests you will advise to confirm the disease? Now vision is 6/6 up till late in glaucoma patient, and IOP may be in the high teens and or even in the low teens. And you can have glaucoma. Cupping is more reliable and the asymmetry highly reliable, but still you have to perform further investigations to confirm it. So we have got 5 combinations. Number 1 is CCT, central corneal thickness, and OCT, optic nerve head. The other one, so it can be performed. A can be right option, but let's go to the second option, which is B, central corneal thickness and visual fields. Now that can also be, but in the A, OCT, optic nerve head is more reliable. In option B, visual fields are more reliable. In option C, again OCT, optic nerve head is more reliable, and gonioscopy you don't need to do because anterior chamber is deep. Then option D, OCT, optic nerve head and visual fields. Now both reliable things are in option D. So our answer is option D, OCT, optic nerve head and visual fields. So if we will get visual field changes and OCT, optic nerve head will also tells us thinning of the neuroretinal rim, so that will confirm that this patient have got glaucoma. Visual fields and gonioscopy option E is also incorrect, because gonioscopy you don't need to do in a deep anterior chamber. Now last question was 60 years old male came with complaints of glare and halos while driving at night, and also decreased vision more in the morning and gradually improves when the day progresses. Now this statement tells about corneal edema in the morning, and then it improves when the day progresses. On slit lamp you found corneal guttata at the back of the cornea at the endothelium. So now it's a clear-cut case. Corneal guttata you get in Fuchs endothelial dystrophy, and in a Fuchs endothelial dystrophy you get glare and halos, and the patients also feel difficulty while driving at night, and they have decreased vision more in the morning, and it improves as the day progresses. So all other options are incorrect. So that was all about today's stage of retina, cornea and glaucoma, and I have tried my best to ask the most important and the most common things that practically we encounter in OPDs, wards, and to check the knowledge about these the most, and I tried to avoid the rare things. So I hope most of the class would have now got some idea that how to attempt the multiple choice questions, and at what stage, how much they have got preparation and how much deficiency they have got, and now they have got the time to improve themselves. Remember, the clock is ticking, the time is running, and now you have to catch it up. Thank you very much.